So BPH is, as the name indicates, is benign prostatic hyperplasia, commonly known as enlarged prostate. It is the most common urological problem in men. That's the number one cause the patients, men can come to see a urologist. So it's very common. There is a questionnaire that we ask patients to fill out. It's called AUA symptom score, or IPSS, International Prostate Symptom Score. And that has a category, 7 set of categories in which we ask about their frequency of urination, their urinary stream, whether they feel empty, whether there is any stop and stream, interrupted stream, urgency, and nocturia, which is getting up at night. So those are the set of questions that you ask, and then you score them. Anything under 7 is basically, you don't treat that. 7 to 14 score is early symptoms, so that most of them will do well on medications. 14 and above is like 14 to 21 is moderate, and over 21 is severe. So anything over 21 definitely warrants treatment with other modalities. But we always put patients on medications first and give it a trial with medications. If they do well, and if their rest of the workup is negative or is under control, then they can continue on that. Apparently, there are some hormonal changes that happen in men as they grow older. It's just like I give example that you can compare it to uterus in women. It's not needed after you have children, So same thing with prostate, except that it is at such a sensitive location that you can't just remove prostates in everyone, because you're talking about urinary control, talking about erections and all that. So, but the main role of prostate is during the sexual or maybe childbearing age, or even though men can still produce sperms, but it is after a certain period of time when it gets enlarged, then it causes blockage of the prostate, of the bladder. So what happens is that the bladder is a storing organ where the urine stores, and urine has to come out. And prostate is sitting right in the middle, right at the beginning of the prostate, and it's just like the barrier. It is, as the prostate enlarges, it narrows the opening or the tube that it's almost like a slit, that goes through the prostate and becomes the urethral tube. So it all depends on the symptoms. If they develop symptoms, then they will need treatment. And a lot of people, now, I would say almost 50% of people after age 50 will have BPH, some degree, but not all of them will need treatment. Compared to that with the prostate cancer, it's almost 5 times more common than prostate cancer. So obviously when the patient comes to see us, how it is diagnosed, patient will come with a set of symptoms. If they have urinary symptoms, you ask them, if they have symptoms, you ask them fill out the questionnaire, so they do that. We do a prostate exam, check the size of the prostate, approximate size, and we may want to do some baseline testing, obviously urine test, and then they check their PSA because make sure they don't have prostate cancer. We can do the flow test in which we measure the bladder pressure, called urocuff or uroflow. And once you have that parameters, then you see if the patients need treatment or not. And then you can start with the medical therapy. That's the first line. There are 2 types of medical treatments. One are the alpha blockers, and their purpose is to relax the prostate smooth muscle, and by blocking the alpha receptors, and that opens up the channel, and the urine flow improves. However, that doesn't affect the size of the prostate, so prostate will basically continue to grow over a period of time, and alpha blockers will stop or maybe not as effective. The other category are the 5-alpha reductase, which is an enzyme that is testosterone is converted to DHT, and that blocks that enzyme. So there is less DHT. So actually, finasteride or propecia, as we call for baldness, is also used. But it ultimately shrinks the size of the prostate without affecting the testosterone. So those are the 2 categories of medications. They are effective, but they are not like long-term. One of the disadvantages is that we underestimate the side effects of medications, and a lot of patients just stop using them because some of them cause ejaculatory dysfunction, some of them cause, especially finasteride, cause erectile dysfunction. So patients will stop using them, and once they use it, it is indefinite treatment. It's not, if you stop them, the prostate will grow back, especially with finasteride or alpha reductase. So once the medical treatment is the first line, then we go into the surgical options. And as we discussed that there are two types of procedures. One is where you remove the prostate tissue, and the other is where you actually do the office procedure to do something to the prostate to shrink it. And in the first category, where is the second category, that where you shrink the prostate, the office procedure is called urolift. This is commonly used at this time. I won't go into the historical treatments that were there, like balloon dilatation. Urolift is one that is commonly used. Resume is another one in which you use the water, the steam we inject into the prostate, and that shrinks it over a period of time. They are not as effective, but they are advantages that they are very safe. They don't affect the erections, they don't affect the ejaculation, but they're not very safe. They're not very effective. So you're talking about something that is more effective. That's where you have to remove the prostate tissue. In that category, you can say that there is a TURP, there is aquablation, and there are other procedures like laser enucleation or open surgery either with a simple robotic surgery or simple open prostatectomy. We remove the prostate. Those are all procedures that take longer time and require hospitalization. Now, aquablation, the advantage is it goes from one spectrum to the other spectrum. It covers all, whereas you cannot do the other procedures for every size. So that's one advantage of aquablation. Even more than TURP. TURP, 80 grams and above is tough to do. So those are the two types. So one is to remove the prostate tissue. The other one, prostate tissue is still there, but it shrinks over a period of time. Before we answer the question whether BPH is related to PSA, PSA is prostate-specific antigen. It is specific to prostate. So anytime a patient has a prostate, they will have PSA. So BPH will also secrete PSA. So people with very large glands sometimes have a high PSA. However, prostate cancer secretes more PSA than normal prostate size or even BPH. So yeah, PSA alone cannot diagnose prostate cancer, but you have to rule it out. You have to make sure when you do BPH treatment, you have to make sure it doesn't have prostate cancer. So if I start developing urinary symptoms, so obviously you will see the doctor if you have symptoms. If you don't have symptoms, you're not going to see a urologist. So most common are these symptom score that I talk about, that you go and fill out the questionnaire, look at the questionnaire and see which applies to you, and you will know, hey, I have urgency, Yeah, I do get up 3 times at night, Sometimes you don't really pay attention to those things unless you really read about that. And sometimes patients go to see you for another reason. They come with ED. And ED and BPH connection is also there. So they have ED, and then we ask them fill out the questionnaire, then you look at that. Patients are having like 3 times at night, slow stream and all that, but they're not bothered by it. They don't even think that that's a problem. They think it's normal. And so there's in the symptom score, there's one category that is called quality of life. I think that is very important criteria to determine what treatment you want to have. Now, if patient is pleased or satisfied or mostly satisfied, then we don't really tell them unless they have very high symptom score. Some people are just deniers, they will not admit that they have a problem. And you have to really see, listen, you're getting up 5 times a night and you're not bothered by it. Oh, I'm fine, it's no pain. So if you have no pain, that's the thing why sometimes you have to explore that. So once you start getting symptoms, then it depends upon how severe the symptoms are. Mild symptoms, medications just, we give them a try. If they work, then they continue on that. If they stop working or the symptoms get worse down the road, mostly it is a progressive disease. It continues to grow. Are there patients where they could have been helped early, but they never sought treatment? I think so. I think a lot of patients actually are diagnosed with urinary retention. So they just all of a sudden can't pee. And sometimes they get anesthesia for any procedure, and they found that they cannot pee. They had no symptoms. But if you go into exploring more in detail, you ask them, were you having any trouble before you had this surgery or anesthesia? Yeah, I was having some symptoms, but I was not bothered by it. She goes, I'm not getting any pain or anything, it didn't bother me. It's a little slow stream, but everyone gets it when they get older. That's how people look at it. Yeah, so those are the patients where if they come early, they can be helped. Because long-term complications of BPH untreated can be very, very devastating, and they can affect the bladder function. You see, bladder is like, is a muscular organ. It contracts, the sphincter relaxes, prostate relaxes, and the urine comes out. If there is a blockage, just like, pipeline is blocked and everything is backed up, just think about your toilet. You see everything comes out, and just like back pressure. That back pressure will affect the bladder, make it thicker wall, so the bladder has to work harder. So it becomes thicker wall. That's why they get urgency symptoms. So urgency symptoms are very important in that category. And if the pressures are high enough, it can affect the kidneys because it gets transmitted to the kidneys. So patients may not notice that, but if you see those changes, then you have to address that to patient. Tell them, listen, if you show them the chart and criteria of what is going on, then they understand it. What are the most common questions? I mean, patients come with problems, I don't think they ask you questions, what should I do? I mean, they will say that, listen, I have trouble urinating. I'm going frequently. My stream is slow. Yeah, I mean, they could say, what can you do? And then we obviously go through the whole process of examining the patient and, developing a treatment protocol for them and go from there. So I think if their symptoms are stable, or if the drugs are helping, that's fine. If they don't have any side effects, that's fine. But a lot of time patients will continue to take them even if they're not helping, because they're scared of surgery. They're scared of other options because they're scared. I mean, that's natural, and it's not something that, you come up with. I mean, if I were in that situation, I would have the same feeling. So I can totally understand that. But I have some patients who don't want to take medication. They say, listen, I don't want to take lifelong medication. I think the question is, what should they should ask that they don't ask. Probably they don't really think that the symptoms they have are abnormal, so they suffer through those without realizing that those are the symptoms that they should not be having. They think it is just part of aging. You ask them, getting up 3 times a night, doc, I thought that's normal. I saw my dad going through that. He used to go to the bathroom and 2, 3 times, 4 times, and I thought that's normal when you grow older. So it never bothered me, and that's the only thing that I would say, that you have to sometime explore when the patient comes to see you for other conditions, other urological, kidney stones, ED. Those are the conditions that we always ask them. Anybody who comes to see us age 40 and above, we ask them to fill that questionnaire, and if it looks at that, when the patient fills it out, then you address that. If they put all zeros, that's great.